You can just blame it on me. I don't even know. So those are the projectors up there. They must just be asleep. It's not. I think I'm in IT. You want me to do that while you wait? Yeah, can you? Yeah. Sorry, we're having technical difficulties. I must be the first one in here this morning. Yeah? No? What? Well, what happened? I don't know how to turn any of this on. It seems like it says that it's on, but it's not. Yeah, Meg went to go get IT, so thank you. When I came in here, and I hooked up like I normally do, but there's no... Looks like there's no power going to the projector.
Yeah, I see it. And now it turns on once I turn the power. I think it was in the process of trying to turn stuff back on or something.
Oh.
I've turned the system off and it's now.
Yeah, it uses the light.
Yeah, that is turned on.
Oh, that looks much better.
That.
Yes.
So once that's done, we should be able to turn it on here.
Okay. Thank you. Sorry.
Has it ever not happened? This is a long time.
Like it was the system was on and on the projector pad,
That should do it. Unless there's
Well, this thing worked yesterday without a problem.
what is? Okay, the PC's working again. But not her.
Oh, here we
It
go.
goes.
Okay, thank you.
Yeah.
Thanks, guys. Okay, sorry. We better get started. We don't have a lot of time here. We've got a couple classes to get through today, so I'm sorry for the delay. There's a chance I did just plug this in upside down or something, but we're working now, so that's all good. Okay, so what I thought I would just go back to this morning is just a quick word on protein binding, because I know I kind of mentioned something about protein binding but didn't really stick with it. So basically, I gave the example yesterday of the tetracyclines being pretty highly protein bound, and what does that actually mean in the patient? Well, what that means, right, is when drug is really highly protein bound, the drug that's bound to the protein is not available to be effective or active. So the free drug, or the drug that's not protein bound, is the drug that can actually cross into the tissues, so out of the vascular space and into the extravascular space, which is technically and typically where most of your infections are going to be. If you're actually treating bacteremia or sepsis, then of course you need some of that drug component to stay in the intravascular space, but a lot of the infections that we're treating are outside of the vascular space in the tissues, right? So again, it's that free drug that is available, and the tetracyclines tend to be fairly lipophilic. So when they're not bound to protein, they can cross membranes. It also reduces drug clearance, and so that will affect elimination half-life. So when the drug is bound to protein, it can't be, if there is some component of it that's going to be excreted through the kidneys, it can't be filtered through the glomerulus because it's basically too big. So then this gives us an ability to, dose things like cephovicin once and have multiple days worth of therapeutic drug on board, if that makes sense. So we kind of can utilize protein binding in some sense to our advantage, and that's one example of using it to our advantage. So it has a longer elimination half-life, and that allows us to give that once, one injection and then multiple days of therapy, which is quite convenient, right? Hence the name Convenia. Okay, so now we need to kind of do a little recall on those classes and their mechanisms of action, like we always do. So the aminoglycosides and tetracyclines are nice, and we kind of grouped them together because they share the same mechanism of action, and they are both potentially nephrotoxic. The aminoglycosides tend to be thought of as more nephrotoxic than the tetracyclines. However, their similarities pretty much end there. So they have a different spectrum of activity. And when we're thinking about specifically the aminoglycosides, do you guys remember what the spectrum of activity is for that class? Yeah, gram-negative and only aerobes, because they use oxygen to get into the cell, so they're not effective in anaerobic environments. And then tetracyclines are moderately lipophilic, and they're broad spectrum, with the added bonus of having good activity against what? What kind of bacteria? Oh, Anaerobacteriaceae, is that what you're saying? Or no, I can't hear you. Yeah. Okay, so pretty good against that, but what sorts of weird organisms are they good at getting? The organisms that live where? Intracellularly. So really we're looking for intracellular bacteria, intracellular organisms, and then mycoplasma that has that weird cell wall, so the atypical bacteria, right? Very, very good. Okay, and then starting off with that little clinical example, we have this, again, this little cute goat. We talked about her a little bit about her presenting signs, and when we did more of an exam and got some blood work, we could see that she had a severe azotemia, so her creatinine was 13.5, her BUN was almost too high to read, and she had severe electrolyte derangements and a very low serum total protein of less than 5. So she had evidence on physical exam of that low protein and holding on to fluids, right? So she was probably kind of overhydrated, she wasn't urinating, and then had a low protein and then got this, what looks like bottle jaw, okay? So this is something that you guys are gonna hear referred to, especially in ruminant patients that have edema. So for whatever reason, edema likes to collect in them under their jaw. Other species it collects at other places, like horses like to get ventral edema and pectoral edema, but it's really common to see bottle jaw in goats that are hypoproteinemic. And in this case, she's hypoproteinemic and overhydrated in renal failure. So basically, this goat was diagnosed with acute renal failure because of 2 hits on the kidney, a nephrotoxic drug given at an appropriate dose, and exposure to oak, which has tannins in them and are toxic to the renal tubular cells as well. So unfortunately, Chloe didn't make it, but this is just a kind of clinical reminder of thinking about other things going on in the patient that can make your antimicrobial drugs potentially more toxic, even at a correct dose and a correct dosing interval, okay? So now we're gonna get into the classes for this lecture, and the fluoroquinolone antibiotics are where we're starting today. They have a unique mechanism of action, so they ultimately inhibit nucleic acid synthesis by binding to DNA gyrase, which is also called topoisomerase 2. They also do inhibit topoisomerase 4 to some extent, and these are non-mammalian topoisomerases, so they're specific to the bacteria. And they basically prevent them from copying their own DNA because they stop that supercoiling, the uncoiling of the DNA from happening. They just stop it in its tracks, okay? Their spectrum of activity is actually fairly reasonable to think of them as similar to the aminoglycosides, where they're very good gram-negative coverage and aerobic bacteria, and not good against anaerobes. But when we think about the fluoroquinolones, they have an added bonus of being more lipophilic than the aminoglycosides, so they can actually also get intracellularly. So they can get some of our atypical bacteria as well. I listed here that they do get some gram-positives, and the main gram-positive bacteria they're going to get are staph, so that again is similar to the aminoglycosides, and some streps, but they're not reliable against all streptococcus. So you don't want to think about that as empiric therapy for an animal that you think has a primary streptococcal infection. They're most effective when they have a high concentration of drug in the patient. So they're most effective when they kind of have that peak concentration and then fall off slowly over time. And so total exposure of this antimicrobial to the pathogen is more effective than just a little bit of being just a little bit above the MIC for the whole dosing interval. So it's more about a big exposure. And then in this particular case, it's kind of looking at the ratio of that big exposure and how long it takes for it to kind of fall off. So I'm not going to ask you specifics about this on your exam, but just to think about how we dose this, this is typically once daily dosing in these patients. The prototypes for this drug are listed here in the blue. Ciprofloxacin is the active metabolite of enrofloxacin, okay? It is not as bioavailable as enrofloxacin. So when you give enrofloxacin to a patient and you give ciprofloxacin to a patient, you're actually gonna have higher concentrations of active metabolite of ciprofloxacin in the patient you gave enrofloxacin to, okay? And then the other drugs that we use pretty commonly in veterinary medicine are marbofloxacin, and there is a labeled drug called the danofloxacin is labeled for cattle, okay? There's also a label for enrofloxacin or Bactral in cattle as well. These other ones, the orbafloxacin and ofloxacin, and they are used for topical ophthalmologic uses, okay? The little pratofloxacin has a star next to it because that's a newer generation fluoroquinolone that's just coming into the market really in the UK first, and I don't think it's available here. But the thing that it touts is that it has more anaerobic coverage, like it will actually kill some anaerobes, but you should think of that as on a case-by-case basis, and it's not broadly anaerobic at all. So it might be useful for some specific anaerobic infections, but not broadly. The route of administration for these are IV, sub-Q, orally, topically in the eye, I'm going to say. And then we have to be really careful with how we administer it intravenously, because if the drug extravasates or gets around the vein, it's extremely caustic because it's a pretty basic compound. And I'm talking specifically about the Bactral. And so that will actually cause necrosis of those tissues around the vein. And you get really severe thrombophlebitis and even perivascular necrosis and sloughing of skin and tissue. So the way to administer that then is through an intravenous catheter and usually diluted out to decrease the inflammatory effect on the vein, okay? Again, the disposition I alluded to before and how it was different from the aminoglycosides, but it's fairly lipophilic, so you get a high volume of distribution and low protein binding. So once you give that drug, either orally and it gets absorbed or IV, it ultimately distributes into all of your tissues very nicely. It has mixed renal and hepatic metabolism and does undergo enterohepatic circulation, and again is a good choice for an animal that has a bacterial infection in the liver. And the main things we're talking about there are either liver abscesses or cholangiohepatitis. For specific indications, It is fairly broad spectrum, so when you are not worried about anaerobes or streptococcus, then that's a fairly broad spectrum choice, which is probably never the case in a horse. So there are certain species where strep is not high on the list of primary opportunistic pathogens, but in horses it is. And so it'd really never be appropriate to use enro as a monotherapy for diseases that we're highly likely to see streptococcus cultured from. And the main things in horses is going to be respiratory disease. But when you combine it with a narrow spectrum penicillin, then you're very nicely covering that component of your gram-positives that you might not be getting with the Baytril alone. It does cross the blood-brain barrier. Again, it's nice and lipophilic, and the blood-prostate barrier as well, so it's a good choice for meningitis or prostatitis. It is labeled for anaplasmosis in cattle and swine and bovine respiratory disease. The main toxicities to kind of remember, especially for NAVLI, are retinal degeneration in cats, and usually this is dose dependent, so high doses of Baytril. Arthropathies in growing animals, it affects how the cartilage forms and can lead to arthritis and cartilage deformation. And the perivascular reaction, which we mentioned. And then we can see sporadic tendinopathies in horses on Baytril, even if they're not exercising. So horses that are receiving Baytril, and this actually was reported in people as well, they're just more likely to get tendinitis that was kind of atraumatic, so they don't need to be out there running or doing anything athletic, but can get very sore, inflamed tendons. And that's usually self-limiting. Once the drug is removed, that improves with just rest and time. So the contraindications here are young growing animals, using it as a monotherapy in equine respiratory disease, and it is not legal to give to a lactating dairy cow. So mostly it'll be on the label to use it in dairy calves or female dairy cows less than 20 months of age. And the major distinction there is that they're not lactating, so then their milk is not going into the food chain, okay? And here, we just, I already mentioned this a little bit ahead, but this is to remind us that giving ciprofloxacin is not equivalent to giving enrofloxacin, because even though it's cheaper to give the Cipro, you're not getting as much drug into the patient. It's less bioavailable than the enrofloxacin. Okay, so now we get to talk back about our clinical case that we left off with, kind of introduced you to the other day. So this mare with terrible proximal enteritis, we've got some decisions to make because she is severely, hypovolemic and has evidence of potentially acute kidney injury with her creatinine of 3. And we need to give her broad spectrum antimicrobials. We're definitely going to rehydrate her and do the best we can to give her fluids to reperfuse her so her lactate comes down and start to diurese her so her creatinine comes down, but we don't want to give the kidney another thing to worry about. So we're trying to avoid what drug? What are we not going to give this horse as part of our broad spectrum antimicrobial therapy? What class? You guys, I hear you saying it a little bit, but it's a class that we talked about at the very beginning. Yeah, we're not giving aminoglycosides, and we probably won't be giving tetracyclines either in this particular case. So what do we typically need to cover in a horse like this? Broad spectrum antimicrobials are required, so we need to think about gram-negative enterics, and we need to think about gram-positives. So we can use something like ceftiofur sodium, which is pretty broad spectrum, does not have a high risk of injury to the kidney, or we can combine potassium penicillin with enrofloxacin, and enro will provide that similar spectrum of activity that aminoglycosides otherwise would have. I guess trying to make the distinction whether you use ceftiofur over potassium penicillin and enrofloxacin is going to really depend on a couple of things. One of those therapies is a lot cheaper to do than the other. Penicillin G, the potassium penicillin is given IV 4 times a day, and the enrofloxacin is IV once a day. And the ceftiofur sodium, we talked about it can only really be given parenterally. It's not absorbed, not bioavailable orally. So your options are, again, IV, IM, or sub-Q, and that's twice a day. So the ceftiofur would be cheaper, But it's possible that in some parts of the country, some horses are really sensitive to ceftiofur, and their GI flora is more susceptible to disruption when they're administered ceftiofur over potassium penicillin and the enrofloxacin. So it could be regional in some instances where we tend not to see a lot of diarrhea, like colitis be caused by penicillin in this area. But if you give potassium penicillin to horses in California, they can have terrible colitis and diarrhea and even death. So they avoid penicillin G, potassium penicillin G like the plague in California, and we can give it very easily here without having that kind of outcome. So kind of knowing your location and what the population of horses in your area can tolerate well is important as well. But if we had a case where they couldn't afford that therapy, then ceftiofur would be a very logical choice and would provide similar coverage to the penicillin with Baytril. And in this case, we're specifically avoiding the aminoglycosides and tetracyclines, okay? Does that make sense? Okay. And our kind of things that we're thinking about here, to how do we treat this animal, are route, cost, and complications. And what route of administration is totally out in this horse, given her problem? Oral, yes. There's no way we can give this animal orals because she's vomiting them all up. And this is the same thing you might have to think about in a dog that you need to give therapy to that's also vomiting. It might need sub-Q drugs or IV drugs for a few days until it can start eating again. Any animal that's off feed that has GI stasis, you could give the oral antibiotic, but it might not be absorbed or might be immediately just come back up in the tube or in front of you. Okay, a little 5-second break. This was a little goat that was missing a leg, and I honestly don't remember the outcome, but we were slinging her, and she was pretty darn happy with a little bit of assistance. Okay, so moving on to another big class of drugs, the sulfonamides and diaminopyrimidine antibiotics, The main mechanism of action for both of these drugs is that they're going to inhibit folate synthesis, and specifically the folate synthesis pathway in bacteria, because we don't have that. We take pre-made folic acid and use it. We can't make our own folate, and so that is what distinguishes this being cidal and toxic to bacteria, but not to us. So folate is a very important cofactor for things that are building blocks for proteins, and so this ultimately inhibits protein synthesis. Specifically, what's happening here are the sulfa drugs are acting as PABA, or para-aminobenzoic acid analogs. So they are the wrong chemical structure, but they look similar to PABA, and they get incorporated in the folate synthesis pathway, but can't go on from there because it's the wrong molecule. The potentiating agents, the diaminopyrimidines, include trimethoprim and pyrimethamine, and what they do is they inhibit an enzyme further down in the folate synthesis pathway, so they are also stopping folate from being produced, but just another step down the chain, okay? So here at the top of this little pathway, we see where the sulfonamides have their activity, and then further down in the process, we see where trimethoprim and pyrimethamine inhibit dihydrofolate reductase, okay? So two little stops along the road to prevent them from making proteins and synthesizing important DNA and RNA, okay? So when these two drugs are used together, they are considered cidal. When you have just sulfonamides alone, we consider those drugs static. They're time dependent, so we often need multiple time-a-day dosing to be able to keep that concentration above the MIC of the bacteria for the majority of the dosing interval. But again, it doesn't matter how high it is really, it just matters that it's above it. And then we just kind of talked about how potentiating them with the trimethoprim or pyrimethamine makes them cidal. And together, they're also more broad spectrum. So when you potentiate the sulfonamides with trimethoprim, they're very broad spectrum. They also get odd things like protozoa and coccidia, and they have not great anaerobic activity, but some, okay? So the main ones that you'd have to think about for this class, which we're gonna definitely see in practice, are sulfamethoxazole and trimethoprim, sulfadiazine and trimethoprim and sulfadimethoxine, which is Albon, and Albon typically gets used as a coccidiostat, okay? The routes of administration are oral or IV, and by and large, we're using these medications orally in our veterinary species. There are IV preparations of trimethoprim sulfa, but we don't use them very frequently in practice. They're nice, they're moderately lipophilic, but they're fairly inefficient in purulent material. And the main reason they're inefficient in purulent material is because when you have pus, you basically have cells that are necrosing and dying and leaking, and so they can take that pre-made folate that's coming from those cells and utilize that, the bacteria can, and just avoid having to make their own folate, and so the TMS is not very efficient in that particular situation. They undergo both renal excretion and hepatic metabolism, and they get pretty high concentrations in the urinary tract, so in the urine, and so they're good options for urinary tract infections. And this is the most cost-effective oral option for an antimicrobial in a large animal like a horse. But we don't use them that much in small animal because there's a lot of toxicity associated with using trimethoprim sulfa in dogs. And the main one to remember is KCS, so keratoconjunctivitis sicca in dogs. This can be a really chronic condition, especially in dogs that are given sulfas over a long term. It can cause sporadic hepatic necrosis in dogs, can cause hypothyroidism in dogs, and then we can also see bone marrow suppression in any species, especially with prolonged use, so chronic administration, weeks at a time. The main thing when you have bone marrow suppression that will be picked up on first, and is really one of the most clinically important things, is that you'll get a neutropenia. So the neutropenia would make you more at risk for secondary bacterial infections, and this is something that is reversible, so you stop the medication, and over a period of days, usually the neutrophil count will rebound. When we have had examples of pyrimethamine overdoses, these have typically been related to mixing errors in compounding pharmacies, and they have been associated with death in horses from severe colitis, myeloid suppression, so they'll be extremely neutropenic, and they also, a lot of those cases got severe laminitis and were euthanized. So that is one example of a toxicity, but from a true overdose. These other things that we're talking about are toxicities associated with chronic use at a standard dose. The contraindications here are that we just really try to avoid them entirely or use as a last resort in dogs. So really only if that's the only drug that's going to be effective against the bacteria or the infection that you're dealing with. And yeah, I think that's probably about it for the sulfa drugs. So we're going to move on to the macrolides. We have coming up the macrolides, lincosamides, and then the phenocols, and they all have a very similar mechanism of action, and they have a fairly similar spectrum of activity as well. So we're kind of taking a departure from TMS now to a group of drugs that are going to be kind of functioning a little bit more similarly. So the macrolide antibiotics, they inhibit protein synthesis via the 50S ribosomal subunit. So a similar mechanism of action of both tetracyclines and aminoglycosides, just a different target. Their spectrum of activity is fairly narrow. They are very good against gram-positive bacteria, aerobes, and select anaerobes. They're bacteriostatic. So remember, we talked about how the aminoglycosides were unique in that they're bactericidal, even though their mechanism of action is inhibiting protein synthesis. But all the other drugs that inhibit protein synthesis are really considered static. So they're also time dependent, so that means multiple time a day dosing often, and they will get some gram-negative pathogens, especially those that are non-Enterobacteriaceae, so things like Pasteurella and Actinobacillus. The prototypes and others listed here, the main prototype is erythromycin. It was the first one really introduced and used clinically. And then newer generations include clarithromycin and azithromycin. And I have them kind of divided by, well, one, oral, and then injectable. So on top, we have orally administered antimicrobials in the macrolide group. And then in the bottom are things that need to be injected to be effective. And they're usually labeled for the cattle and swine. So erythromycin, clarithromycin, azithromycin are all things that we would give in young foals that were not, that were still nursing. So nursing age foals with a certain disease we'll talk about. And then tylosin is given to some small animals for a condition that is not related to an antibiotic use per se, but for reducing inflammation in the GI tract. And we'll talk a little bit about that in a minute. The route of administration, again, I tried to split it up, so I just kind of kept the route of administration similar to what how the prototypes were broken up. They are nice because they're highly lipophilic and they get high concentrations of drug in the leukocytes. So the leukocytes in the area of infection kind of have a little depot of the drug. And that's why when you get a Z-Pack, if anyone's had a sinus infection or a bronchitis that they couldn't clear, you might get a Z-Pack where you take a high dose of the drug the first day and then take a few more days of antibiotics, but really you're getting coverage for almost 2 weeks from that Z-Pack. So it's really cool because you're utilizing the fact that they concentrate in those leukocytes, and over time the drug will elute in that site of infection. So that's how they have that significant post-antibiotic effect, where they're still efficacious against bacteria even after they've dipped below the MIC, because they're still, so the MIC that you'd have in the plasma, they're still available in the tissues. For specific indications, the main one for us is Rhodococcus equi, and we usually combine that with rifampin to prevent resistance. And then we can also, there's specific labels for the macrolide antibiotics for bovine respiratory disease complex, okay? But we are easily and happily using these in nursing age foals, but we are taking a big risk if we use these in hindgut fermenters because it can result in fatal colitis and often does. And this is even at low doses of exposure to this drug. So for example, if you give a nursing age foal erythromycin, and then it's an oral drug, so you're giving it in its mouth. If it goes and dips its mouth in the water bucket next to the mare and the mare drinks from it, that could be enough exposure to that drug to cause fatal colitis. And the main thing there is, again, the spectrum is fairly narrow. It's really lipophilic, really good for gram-positive bacteria. So it can very quickly wipe out the hindgut. So the gram-positive cellulitic bacteria that really are the powerhouses of the equine hindgut to ferment all of that roughage, it can wipe them out fast. The other thing that we're going to talk about in a minute here is it has that effect of being specific against those bacteria, but it also works by affecting motilin receptors in the gut itself to contract. So you get a very severe dysbiosis, and then you get cramping and motility of the GI tract, and can get peracute colitis, where they basically die of colitis before you actually ever see them have diarrhea. And so macrolide antibiotics should either be used in extreme caution or never given to things like adult horses or things with hindguts like bunnies and guinea pigs. Telmicin, this is another thing that would come up on boards, is cardiotoxic to people and goats. So using telmicin and accidentally stabbing yourself as you're trying to drop the drug or something would be a big problem, and you'd want to go directly to the ER and have your heart rate and rhythm monitored and all of that. Erythromycin and the other clarithromycin and azithromycin to a lesser extent can cause hyperthermia in foals due to partial anhydrosis. This is reversible, so basically they have a reduced ability to sweat when they're on the medication, but then we remove the medication at the end of the disease process, and within weeks they're able to sweat again. So it's not something that they can't sweat for the rest of their lives, they just really can't sweat when they're on that medication. And this is really important to know. It might seem like, oh, okay, they can't sweat, that's weird. But when we're usually giving this drug is to nursing, weaning age foals that are in the middle of the hot summer because they were born sometime in January to May, And then by the time they get rotococcus, it's like August. And so you're giving them this medication, and if you don't tell the owner to keep them up, cool them off with a hose, you'll be treating them for respiratory disease, but they'll be out in the pasture blowing like freight trains, looking like they're in respiratory distress because they can't cool themselves. So it's not just like a, oh, cool thing. It's like, oh, we really need to tell the owners this so they don't overheat and then, die from heat exhaustion after we're treating their rotococcus. So again, contraindications for these drugs are we don't give them to hindgut fermenters. Dead bunnies. I usually think that's a really powerful image. No one wants to see a dead bunny, at least I don't. So the macrolide antibiotics are pretty cool. They have some other anti-inflammatory effects as well. So they can reduce airway mucus secondary to effects on interleukin and neutrophil influx, and that helps in respiratory disease, right? So you're killing the bacteria that are causing the inflammation, and then you're trying to calm down the inflammation in the lungs and the mucus as well. So that's like a double whammy. That's a really good drug. Tylosin, as I said, is something that they use in companion animal medicine for the treatment of inflammatory bowel disease. And I did attach a JAVMA paper to your ELC that you guys can look at if you're interested, because I thought it was a pretty nice little review, I think it looks at efficacy of that. It's a terrible disease, it looks like, to deal with in dogs. Like diarrhea in dogs is just such a nightmare. And so it looks like when they are treated with Tylosin, they can be on that drug for months at a time. And I'm not sure that it's curative, but it does help with the symptomatic problem of diarrhea. And as mentioned, it does also have prokinetic effects. So both erythromycin has been looked at both in horses and cattle post displaced abomasum to see if that can improve abomasal motility in those animals that get atony. And it's one of those things that we need to really think about thoroughly, because the effects of giving a very low dose, so this, I told you can't give erythromycin to horses, so how the heck are we giving erythromycin to treat ileus? Well, we're giving it IV and a very, very low dose, so a sub-therapeutic dose that you would not be effective at killing or treating an infection. But we need to think about what the impact that could have on overt resistance in the population of bacteria that then is exposed to some degree to small amounts of erythromycin. And so we tend not to use that because we have other prokinetics that are available to us that are not antimicrobials. And none of the prokinetics that we have available are have that good of a success rate. So it's not like, well, erythromycin is so wonderful, but it's an antimicrobial, so we have to use something lesser. All of them are about the same in terms of efficacy. Okay, so now switching to lincosamides, which are kind of similar to macrolides. They have the same mechanism of action, actually the same site of inhibition of the 50S ribosomal subunit. So that means it would be silly to ever use those two drugs together. There'd never be any reason to do that. They're also time dependent and they're bacteriostatic. No surprise there. You guys guessed that already by knowing their mechanism of action. And they have a narrow, very similar spectrum to the macrolides, where they're gram-positive aerobes. The only thing is that they're very good for anaerobes, and macrolides are so-so for anaerobes. They have intrinsic resistance to the Pasteurellacea family, so things like Pasteurella multacida and Enterobacteriaceae, so that's like E. coli, Klebsiella, all those gram-negative enteric bacteria. The prototypes are clindamycin, lincomycin, and perlomycin. Clindamycin is something we can give orally to cats, very carefully though, because it causes profuse salivation, and they have the similar problem of getting esophageal strictures and problems when giving tablets of clindamycin. Lincomycin is labeled for use in pigs, and perlomycin as an intramammary infusion for cattle is really the only way the lincosamides are labeled for cattle. They're highly lipophilic, so they're really good to get into abscesses, oral abscesses in dogs and cats, staphylococcal infections. The lincosamides are a perfect class for that. And then again, because of their high lipophilicity, they're great for dental disease or osteomyelitis. But again, fatal colitis, remember dead bunnies, and they can get diarrhea in nursing puppies and kittens if the bitch or the, I want to say dam, but what is the cat called? The queen, right, is given clindamycin. So don't give these to hindgut fermenters orally, and don't give them to cattle orally. That's illegal. Okay, now chloramphenicol. Chloramphenicol is a little bit different, the phenicol antibiotics, only because they have a different binding site than the macrolides and lincosamides, but also they have some different toxicities, and we do use these as oral administration in horses, and there's labeled products for food animals, okay? So the spectrum of activity is, again, they're time dependent, so multiple time a day dosing. They're bacteriostatic when we're talking about chloramphenicol, but fluorphenicol, which is another member of this class, is bactericidal against select pathogens. Very broad spectrum activity, gram positives, gram negatives, anaerobes. We think of this as a nice broad spectrum drug, and that is different again than the lincosamides and macrolides, which are a bit more narrow, okay? The main drugs in this are easy. There's just two, chloramphenicol and fluorphenicol. Fluorphenicol is the synthetic injectable medication, and chloramphenicol is an oral tablet. The disposition is that, again, they're highly lipophilic. They just go right across that blood-brain barrier, right into the prostate, right into any of the privileged sites. And they generally undergo hepatic metabolism with some renal clearance. This is, if we're thinking about a specific indication, it's a good drug for treating long-term osteomyelitis or abscesses, and fluorphenicol is labeled for foot rot, BRD, and swine respiratory disease, so bovine respiratory disease and swine respiratory disease. However, there is some toxicity associated with chloramphenicol, but mainly in people, and this is what would be definitely a board's question, but there are people that are susceptible, genetically susceptible to exposure to chloramphenicol, and they can get fatal aplastic anemia. And so that is no joke, because fatal is used. That means it's irreversible. Aplastic anemia, where all the bone marrow is done making cells. That's very bad. So how do we use this in practice if there's a small portion of the population that could get fatal aplastic anemia? Well, what's actually interesting is that in some other countries, not really in the US, they actually give chloramphenicol to people to treat certain things. And I want to say like malaria and leishmaniasis and some of those really devastating diseases, because it's such a small genetic pool that's actually susceptible to this. But it doesn't mean it's nobody, so we have to be really careful. And so when we administer this to horses, we need to protect ourselves and protect the owners giving it. Same thing if this is a drug that's being given to a dog in a suspension or whatever. And so you never want to crush up the pills if you're giving the pills. You basically soak them so that way you're not aerating them and inhaling them or getting them in your mouth. Because again, this is exposure through ingestion mainly, so you'd have to kind of get it into your body somehow. So touching it really wouldn't be a problem unless you got it, you absorbed it, if that makes sense. For fluorphenicol, the main concern is that it causes really severe injection site pain, can cause GI upset in any animal, but this is mainly a drug that's being used injectably in food-producing species like cattle, sheep and goats, and swine. It can cause colitis in horses, so we do not give fluorphenicol injectably. We don't use it really at all in horses, which is different than the fact that we're giving chloramphenicol orally, and we don't see a lot of colitis in particular with that drug. The main contraindications are hepatic or renal disease, dogs on phenobarbital because of the metabolism in the liver. That's going to change how much phenobarbital they have available to them, because it's going to decrease metabolism of phenobarbital. So that's going to affect how you dose that drug as well. You'll have higher concentrations in the plasma. And then chloramphenicol is banned in food-producing species. And again, we don't give fluorphenicol to horses. Oh my gosh, I can't believe we got through all of that. Oh, I even got through early. Okay, this is pictures of my kids doing stalls, but I think we should take like a quick break and just introduce the next lecture, because then we could have more time at the end, right? Okay, yeah, we will, really quick. I guess you have no choice, sorry. I mean, I only really have 5 minutes, right? So I don't think we're going to get that far. Oh, good point. It's not on ELC, so I won't do it. You're right. We'll get through it next time. And if you guys can think of, if you have questions or anything or feedback, that'd be great. And when I'll make sure that I have the study guide for both this lecture and or next week's lecture posted before next week. And also, I think I give some examples of questions that I would ask on the exam, so you can get an idea of what that's going to look like as well. Okay? All right, thanks. Yeah. Right, exactly. So in vitro, in the tube, if you mix them in a syringe, they will inactivate each other.
Is that like common for other antibiotics, or is it just like a rare few?
I mean, I would say that I don't know if there's other examples of that we know about their in vitro interactions, but it would be such a rare day that you would combine two completely different drugs in a syringe to give IV. Because that would be really unfortunate to like not know which one they had a reaction to. Or...
So if you were like gonna treat with both types, if you give one IV, like does it have to clear the plasma before you give the other one? It's
no,
just
it's only in vitro. So it would only be if they mix in the catheter, if they mix in the syringe, in a bottle, that would be no good. But once they're in systemic circulation, they're not interacting, and yeah.
Okay.
That's a good question.
So like if you had one on a CRI, which I don't know if you would.
Yeah, you would never give an aminoglycoside on a CRI.
Right.
It wouldn't work.
So you just would like make
Stop
sure not
it.
to run it through the line together.
Exactly.
Make sure it's clear.
Yeah, and that's like a pretty good rule of thumb for like most drugs. Like I know there's a lot of like infusions that we end up giving like lidocaine and end up putting a lot of stuff in that, but in general it's good to like stop constant.
Yeah.
So they don't.
So I think we use metoclopramide a lot, and it doesn't. No, it on dance contains everything.
Does it precipitate with it?
Yeah. So we have to like if they're on that CMR, they have to like do flush before and after.
Yeah. But that's a really good example, and I don't know, maybe that's in my notes. If it's not, I'll add it because you don't want to mix those two, especially in a syringe together, because it seems like, oh, well, they're synergistic together in the animal. Why not just put them together? Yeah, they'll inactivate each other. That's really good.
So I have a question. When we were talking about sulfonides, is that the same as a sulfa drug, which are antimicrobial?
Yeah, they're sulfa drugs. And antimicrobial, yeah, I mean, the sulfas are, I feel like they're all synthetic, so yeah, they're antimicrobials. Is that what you're...
Yeah, no, like, so for undergrad, like, we had an entire, like, antimicrobial resistance course within our major, and they broke it down as, like, sulfa drugs as being considered antimicrobials instead of, like, antibiotics.
Okay, so that is semantics, right? Like an antimicrobial is a drug that is synthetically made.
Yeah.
So yeah. So but it acts as an antibiotic, right? Like it's. I mean, I don't know if that you can. If that distinction is that important, except that when you're talking about an antimicrobial, that implies that it's being synthetically produced.
Okay, and then my other question is when you're using sulfa drugs, because it's normally, or at least the times I've seen it, it's oral in horses, do you have to worry about ulceration?
Yeah, we don't really see a lot of ulceration
So
with that
it's
particular
not too
medication.
bad. Okay.
No, like not, you mean like oral ulcers
No, like
reaction?
gastric.
Oh yeah, no. Yeah. NSAIDs, yes.
Yeah.
I can't really think of any antimicrobial that I associate with like promoting ulcer formation. I don't know. Yeah.
Yeah. No,
That's a good question.
I've just seen some vets that were like very against sulfur drug use, and I always wondered why. You know?
Well, they're not always that effective.
Yeah.
In some cases, but and they get overused terribly. And the dosing ranges that people use are all over the place. You know, like there's labeled Uniprem, which is just giving the powder once a day, versus really it's a time-dependent drug, so it really needs to be given twice a day. The dosing range is like 15 to 30 mg per kg. So if you're really on the low end of that dose, I don't know. And people, they can get colitis with it, just like any other thing. So maybe they've had bad luck with that too, diarrhea. So, yeah.
Thank you very much.
Yeah, of course. Yeah.